Okay. Hello, my name is Dr. Diana Feldstein, and I am a physician volunteer with the MAVEN Project. Thank you all for joining us and our friends at our anchor clinic today, which is St. Joseph's Chandler Health System Incorporated. And thank you for hosting today's session. We are going to talk, Dr. Wright is going to go over his slides for what a primary care provider needs to know about CKD. After fellowship, Dr. Wright became the medical director at the dialysis and at the dialysis unit at the Brooks Center Army Medical Center, and then director of the Nephrology Fellowship. After separating from the Army, he went to practice with the Jackson Clinic in Jackson, Tennessee, where he established the nephrology service. Dr. Wright retired after 35 years of practice. During those years, he served as the clinic's chairman and then the medical director. So with that, I'm going to turn it over to Dr. Wright. Thanks, guys.
Good afternoon. Today we're going to talk about what a primary care provider needs to know about chronic kidney disease. And as I was telling Dr. Feldstein before we went live, I've spent my life talking about these things, and I could talk all day about it, but you don't want to listen to it all day. So I've tried to condense this down into the new things, the things that are new and different and controversial, and hopefully things that you're seeing in your clinic. There will be plenty of time for questions at the end. The slide deck is there for if I go too fast and we miss something. But this talk has no conflict of interest to disclose. It is approved for Category 1 PRA credit. And my objectives today are for you to be able to explain the importance of the estimated glomerular filtration rate in diagnosing kidney disease, but also to recognize its limitations in your individual patients that you're seeing in the clinic. I want you to be able to emphasize the role of proteinuria measurement in diagnosis, prognosis, and as a therapeutic target. I want you to be able to describe strategies to delay chronic kidney disease progression in at-risk patients using ACE inhibitors, ARBs, the SGLT2 inhibitors. We'll also talk about GLP-1 inhibitors and finerenone. And lastly, to support patients in aiming for a dialysis last or never outcome over a dialysis first approach. But let's start with a case presentation, somebody you might see in your office. 36-year-old fellow presented to the emergency department for care of a severe laceration in his arm that he got in a motor vehicle accident. He was noted on part of his intake exam to have hypertension with a blood pressure running about 190 over 110 on several occasions. So they got some basic labs showing a hemoglobin of 13.2 with normal indices, normal electrolytes, a BU and a 24, and a creatinine of 2.1. He's referred to you for follow-up of his acute kidney injury. So one of the first questions you have to ask yourself is this really acute? It'd be helpful if you had an old creatinine, but we usually don't. Acute kidney injury is upcoding for hospitals, so there's a bias toward calling it acute, when in fact we just simply may not know where there was before. And bear in mind that sometimes all you can find is a statement that things were within normal limits, but that sometimes means we never looked. A couple things to emphasize, one of which is not terribly obvious, is that the past medical history. Was he really sick as a kid, or he ever told he had hypertension or an abnormal urinalysis? Since he's a guy, he may have tried to play football or some other sport and had a urinalysis done as part of a routine physical exam, may have had his blood pressure checked for the same reasons. And then family history, which is something we usually don't pay a whole lot of attention to. There's some new observations about familial clustering of CKD that I want to talk about. The classic hereditary kidney disease is autosomal dominant polycystic kidney disease, which is the prototypical. There are two genetic markers that have been identified called PKD1 and PKD2. And these are all examples of what we call ciliopathies, because the problem appears to be in the motility of the ciliated cells in the kidney collecting tubule that cause them to become cysts. One of the myths is that families have a typical time to develop end-stage kidney disease. So daddy got on dialysis at 40 and I'm 38, so I'm going to go on at 42. That's not true. And then if they present with pain, hematuria, and enlarged kidneys, you have to be aware that sometimes these are considered cancer. And I've seen patients who've had nephrectomies done only to discover there was no cancer and it was polycystic kidney disease. There's some newer non-traditional markers that you don't test for routinely, but explain some of the clustering that we see. One is the ApoL1 cluster. and then the myosin heavy chain 9 chain, both which have higher frequencies in people with sub-Saharan African ancestry, and in locations with high frequencies of endemic trypanosomiasis, which probably allows for it to stay in the population. Estimated glomerular filtration rate. You're going to find me saying estimated several times, and I'm going to say it over and over again. It's estimated, it's not measured. This is a calculated lab test with all that that implies. So if you look at this as a number in the same way that you look at potassium as a number, you can be led into a bunch of serious logic errors that'll get you and your patient in trouble. So you're going to want to keep in mind that this is just a number, and it's just a calculated number at that. However, having said that, it's central for diagnosis of chronic kidney disease and is an indicator for the timing of clinical decisions, which we now call stages. The current lab formula is based on newer methods for measuring creatinine to the second decimal compared to earlier versions. And the formula was originally published in connection with the MDRD study, and it had adjustments for Black race and all others, which has now begun to be phased out. Many of you have heard of cystatin C, which is an alternative measure for kidney function, which is not terribly expensive, but it has yet to become routine. It has some advantages in the sense that it's not influenced by muscle mass or lack thereof, but it is influenced by inflammation, and a lot of kidney patients have inflammation, which will change the cystatin C level. And I'm going to say it again, remember E equals estimated, so if it actually matters, you're going to want to measure the GFR, but most of the time it's good enough for decisions on clinical grounds. Urinalysis is important, but I find that it doesn't get done nearly as often as blood work. We seem to be A-OK with sending the patient to the lab to get blood work, but we don't usually throw in a urinalysis at the same time for reasons that are obscure, because the test is cheap, easily done, and doesn't cause any pain. You're looking for red cells. If you see red cells, that's important, but if you see red cell casts, that's very important, but it's uncommon. Most commonly seen in early specimens early in the day, and we usually see our patients later in the day, so the casts have broken up. White cells can be present, and be aware of the tendency to write all white cells off as urinary tract infections, because in an office-based practice, 90–95% of the people you see with white cells in the urine, in fact, have a urinary tract infection, but not all of them. Granular casts are non-specific and usually related to proteinuria. Protein excretion is important, and it's a marker of prognosis and disease state and a therapeutic target. And older labs will still give you urine protein creatinine ratios. What you really want to get is a urine albumin creatinine ratio, because it's more specific, and more labs are switching to that. So I think that it depends on where you are in your lab. So I've got both of them in here, not to confuse the issue, but to try to make it so you can adjust depending on where you're working. First off, is a marker of comorbidity. This is albumin excretion rate in the urine in funny units called micrograms per minute. We don't normally think of it that way, but that's the way you could do it. And what you want to see is that the hazard ratio for cardiovascular disease on a log scale on the left goes up substantially as albuminuria increases. So the simple presence of proteinuria increases as a marker of coronary artery disease, which will turn out to be relevant as we talk about the clinical situation later on. There is also on the dipstick, which has a test for protein, a correlation between the amount of protein, in this case protein creatinine ratio, and the 24-hour urine protein versus the urine-specific gravity. So the further away from 1.010 your specific gravity is, the more inaccurate your test becomes. So the dipstick urine is not a good quantitative analysis. It's a qualitative analysis to let you know, oh, gee, maybe I better monitor or measure the urine albumin creatinine ratio. If you know the age, sex, the estimated glomerular filtration rate, and the urine albumin creatinine ratio, you can estimate the risk of progressive kidney disease over the next 2 and 5 years. There's a 4-factor model and an 8-factor model. The 8-factor doesn't actually do anything that the 4-factor doesn't do. And I've given you 2 websites, and you can get to those easily enough by just Googling KFRE. They all overestimate the risk of end-stage kidney disease because of the competing risk of death from cardiovascular disease. The worse your proteinuria, the worse your chronic kidney disease, the worse your chronic kidney disease, the worse your risk of coronary disease, and therefore the risk of dying of coronary events. In our patient that we started with, who's relatively young, there are some other diagnostic considerations. primary kidney diseases or secondary kidney diseases, the chicken or the egg. More primary renal diseases have specific therapies, but they need expert consultation, lab work, and often a biopsy. So those are patients, if it's an issue, you're going to want to refer to local consultation. Secondary causes are way more common and are usually due to diabetes and hypertension in the United States and malaria worldwide. Screening for collagen vascular diseases with things like ANAs, complements, and so forth are common, but may not be cost-effective without clinical symptoms. The same is true for screening for cancer, which has the same problem, although in membranous nephropathy, which is the most common biopsy diagnosis in adults, there is a tendency for the so-called PLA2R lesion to be associated with benign disease and the thrombospondin 7A marker to be associated with malignant disease. And as I said, infectious diseases, syphilis, hepatitis B, C, and HIV are reasonable in your clinic-supported populations, and malaria is common worldwide but rare in the United States. So what I've said so far is genetic factors are important, particularly in patients of African ancestry. Proteinuria is important, preferably albumin, for both diagnosis and prognosis. Kidney failure risk equations are available to estimate the 2- and 5-year probability of end-stage kidney disease, but overestimate the risk because of death from coronary artery disease. And remember, eGFR means estimated. It's useful, but as a guide, not an absolute. The patient's clinical status still matters. So you've decided this patient has chronic kidney disease, so what are you going to do about it? Basically, there are 4 things to do: blood pressure control, diabetes control if they're diabetic, avoidance of nephrotoxins, particularly non-steroidal anti-inflammatory drugs, and PPIs. Both of these are somewhat controversial, but it turns out that a prolonged therapy like daily use for many years is common with both of them and may be a problem. Short-term 2- or 3-day course of a non-steroidal anti-inflammatory drug or a week of a proton pump inhibitor may not be all that bad for you. It's controversial. Proteinuria reduction is going to be something we're going to be doing a lot of talking about because that's our primary goal of therapy these days. And we have 5 classes of drugs. I only have 4 on the slide because I failed to update it. ACE and ARB are the sort of the mainstay mineralocorticoid receptor antagonists. Non-steroidal anti-inflammatory can be used in dire circumstances. The SGLT2 inhibitors and the GLP-1 inhibitors have a role to play as well, which we'll talk about. Let me give you some thoughts on hypertension. ACE and ARB are generally desirable. They're cheap. ARBs are not so cheap. Hyperkalemia can be a problem, and the idea that you give somebody a second drug so they don't have to take the first one doesn't make a whole lot of sense. But a lot of patients, if they keep their potassium intakes down in their diet, can tolerate these drugs quite well. Volume control is a key issue in controlling hypertension in patients with CKD, particularly those with stages 4 and 5. And generally, you're going to need to use a loop diuretic as thiazides don't have much effect. The exceptions to this may be indapamide in a patient with no evidence for volume expansion, and maybe chlorothalidone, although the study that was in the New England Journal a couple of years ago added chlorothalidone to loop diuretics. Diuretic resistance occurs commonly in patients with nephrotic syndrome. Remember, the loop diuretics work from the luminal side of the membrane, so adding something like metolazone probably helps by a direct action on the distal convoluted tubule. Is there a blood pressure target that really makes sense? Sprint's final report included 9,361 patients with hypertension at increased risk of cardiovascular disease. These patients did not have diabetes and were randomized to intensive, meaning a systolic goal of about less than 120, compared to a usual goal of a systolic less than 140, and were followed up for 3.3 years. The goal was to reduce the composite outcome of heart attacks, acute coronary syndrome, stroke, congestive heart failure, and death. In the final report, the composite event rate was 1.77% annually in the intensive group versus 2.4% in the usual group. So what it really says is the absolute benefit is something on the order of 0.7% per year, which means you treat a lot of patients to get a benefit. The all-cause mortality showed similar reductions with the intensive goal, and that was the bottom line headline news that got into the guidelines. Adverse events, though, also went up in the intensive versus the usual. So hypotension occurred in 2.1, nearly double. Syncope 2.1, and acute kidney injury 4.1 versus 2.5%. So they nearly doubled as well. AKI is common, as I just noted, and the question is whether the 30 to 50% relative risk reduction for ESKD continues once patients have eGFRs that are less than 30, or are you hurting the patient by having them on a drug that can make their creatinine go up? So there are two facts to keep in mind as you think about this problem. The first is the relationship between creatinine clearance here on the x-axis and the plasma creatinine on the y is logarithmic. So the small changes in kidney function at the end of life make big differences in the serum creatinine, but early on when most of the disease is occurring, very small changes occur in the creatinine with big changes in creatinine clearance. And you generally have to get below 50% reduction before the serum creatinine exceeds the upper limit of normal, which is one of the reasons behind using the estimated GFR equation. The other thing to remember is that under normal circumstances, renal autoregulation occurs, so that as your mean arterial pressure varies somewhere between 60 and 160, you have stable renal blood flow. If you get below that level, your renal blood flow will fall. And so that may have something to do with the hypotension problem and the AKI problem with the use of these drugs. So what do we know? There are two studies. The first was published in the New England Journal of Medicine in 2022. There was 411 patients in the United Kingdom with CKD 3 or higher who were randomized to stop or continue their RAS inhibition and followed for 3 years. Their bottom line conclusions: among patients with advanced and progressive chronic kidney disease, discontinuation was not associated with significant between-group differences in the long-term rate of decrease in the eGFR. So it didn't help keep the kidney function going to stop the drug. Didn't make it any better to keep it going either. So you can look at that either way. ESKD, or the initiation of renal replacement therapy, occurred in 62% in the discontinuation group, 56% in the continuation group. The hazard ratio it crossed 1, so it was not statistically significant. Adverse effects were similar, and deaths were similar. The second study was published this year in the Annals of Internal Medicine in July. It was a meta-analysis of 18 trials with 1,739 patients with a mean eGFR of 22, and a hazard ratio for renal replacement therapy with RAS inhibition was 0.66. So there was no effect on mortality risk, no observed interaction with age, eGFR, albuminuria, or diabetes. I've given you the bottom line first. The slides are impressive, because what you can see is, depending on how you look at it, the top slide on the left is the one that you care about, which is the patient who's taking the drug, and not taking the drug. And the patients on the bottom, a solid line, are the ones who are taking the drug, and the differences are substantial no matter how you slice and dice it. This looks at the various things the same way, and you can see some of the studies are significant, some are not. So my conclusion from these studies is lower targets have lower event rates over the intermediate term, but at the cost of increasing complication rates, particularly hypotension and AKI. So as always in clinical medicine, it's a matter of patient selection, considering the goals, competing risks, and the tolerance of medical therapy. While we're fond of the more is better theory of medical care, it's rarely true. Remember, aging occurs in everyone, albeit at different rates. Goal for medical care changes with age and comorbidity, so your job as the primary care person is to keep updating the goals. The goals for blood pressure control in an 80-year-old aren't necessarily the same as the goals for blood pressure control in a 40-year-old, but most of our guidelines are written on the assumption that everybody's going to live forever. And Dr. Feldstein's a geriatrician, so she can chime in on this later if need be. Dapagliflozin was the first of the SGLT2 inhibitors to be reported. This study from the New England Journal of Medicine in 2020 is called DAPA-CKD and shows you how it compares to the other DAPA studies that were published looking at cardiovascular safety and heart failure trials. What all of these studies show, if I can make my arrow work, is that you get a substantial reduction in the hazard ratio compared to placebo for both kidney disease and for heart failure when using these drugs, which is why they've become more popular. The actual study was 4,304 patients with or without diabetes, with an eGFR between 25 and 75 and a urine albumin creatinine between 200 and 5,000. They did a composite endpoint of a decline of eGFR of greater than 50%, end-stage kidney disease, death. The trial was stopped early when the hazard ratio was 0.56% in treated versus control, and death occurred in 4.7% of the patients on the drug compared to 6.8% of the patients on placebo. So renal protection seems additive for patients with established diabetic renal disease when combined with an ACE or an ARB. That statement is limited to eGFRs greater than 25 at the moment, although it's being actively studied to see whether the benefit persists with more severe degrees of chronic kidney disease. It is associated with natriuresis, that's part of its mechanism of action, which is probably why it's particularly good in heart failure with reduced ejection fraction. It's also associated with acute kidney injury, especially in patients on ACE and ARB. They cost a lot of money. There you have to do patient selection, and you have to decide whether or not you'd use it or a GLP-1. Fournier gangrene has been reported, and it got a lot of negative press, but it's not clear how much the risk really is, and there may be a risk of increased lower extremity amputation with these drugs, which is yet to be defined. So what I've said is blood pressure control with ACE or ARB help delay progression. The goal is uncertain, but guidelines recommend the sprint targets if possible, using standardized blood pressure measurements, not usual blood pressure measurements. I don't know how it is in your clinic, but in my clinic, the patient would come in, deal with the front desk, deal with some paperwork, walk into the office, somebody would slap a blood pressure cuff on and squeeze it up, take a blood pressure, and write it down. That's not what they did in Sprint. What they did in Sprint was they walked the patient back, put them in a room with a dim light, gave them headphones and gave them their choice of music and let them listen to quiet music for 15 minutes while an automated blood pressure cuff took 3 blood pressure cuffs and blood pressure readings and averaged to 3. You might expect that the second measurement is necessarily lower than the first measurement, even in the same patient. And on average, it's about 7 to 8 millimeters of systolic blood pressure difference between the two. So the difference between Sprint 120/80 and the Joint Commission's recommendation for 130/80 may not be all that different. The SGLT2 inhibitors are the hot new kids on the block. They're becoming more widely used. The academicians are decrying their lack of use, but there's still some barriers to getting them started in patients. And the GLP-1 antagonists also delay progression, as shown by a new study called the FLOW study, which was published July 11th of this year. And it's the effect of semaglutide on chronic kidney disease in patients with type 2 diabetes mellitus. Another big study, 3,533 patients with an eGFR of 25 to less than 50, urine albumin creatinines of 300 to 5,000, and a median follow-up of 3.4 years. They did a major kidney disease event, which is a composite of ESKD or stage 5 chronic kidney disease, 50% reduction of eGFR baseline or death from kidney-related or cardiovascular causes. There was a 24% relative risk reduction in the treated group with a mean decrease rate at 1.16 milliliters per minute lower or slower compared to the control and 20% lower relative risk of death from any cause, which is shown in this slide. Now, what's different is if you look carefully, maybe a little hard to see, is that the benefit didn't show up in the first 12 months, which is different from most of the other studies where the event shows up early and persists. Here, the difference showed up about a year into the study and persisted for over 5 years. So the bottom line is this drug appears to have a role as well, although, as you know, is expensive and difficult to come by right now. Let's talk about renal replacement therapy, which is what we're trying to avoid with all this. I don't expect you to know much about it, but your patient's going to expect you to have some general opinion on it. First off, they're difficult medical regimens for the best patients to follow. Restrictive diets are involved, complicated drug regimens, dialysis 3 times a week or daily if you're doing peritoneal dialysis, clinic follow-up for transplant, lifelong medications. So the question is your patient a candidate, and what can your patient expect on average? These are old slides, but they haven't changed very much. What they show is all-cause mortality from 2001 to 2016 in the dark line for dialysis, the dotted line overall, and the colored line for a transplant. Generally, transplant patients do better in all these studies, but transplant patients are generally younger and healthier because they were selected for transplant. And what you can see is that over the last 15 to 20 years, and this is reported here, mortality rate generally improved, but was still quite high, running around 16 to 18% overall. Adjusted mortality in the first year is substantial. As you can see, the hemodialysis mortality peaks at about 2 to 3, at roughly 20%, and then comes down over the first year and averages about 15% after that initial run. This shows all-cause mortality from 2010 to 2020. This is more recent data. What this shows is the general improvement had slowed down but was persisting until COVID. COVID caused a real problem with dialysis unit statistics. So all the statistics from here on out are going to have a COVID bump. They're going to have to be dealt with. What you need to know, of course, is when I think a referral to a nephrologist would be a good idea. If the patient's acutely ill, it's a good idea, of course, and you're probably going to send them to the emergency department. If the patient shows an active urine sediment, meaning lots of red cells, white cells, CAS, that kind of thing, renal biopsy and aggressive therapy may be indicated. You might consider it if the patient has greater than 300 milligrams per gram on his urine albumin creatinine ratio as well. In the patient we use as our example to start with, referral is not urgent, but he does need a urine albumin or urine protein for determining his end-stage kidney disease risk. Remember, as a nephrologist, I don't have any tools for medical management that you don't have. Monitoring lab quarterly is helpful to get an idea of the tempo of disease, but if it's stable, you can back off. And if the patient's a candidate for renal replacement therapy, it's okay to wait until they get to stage 4. Lots of stage 3 patients won't progress, but only time will tell. One last thing I have to talk about, since this is the MAVEN talk, is dialysis care is funded mainly by the federal government, which bars reimbursement for treatments referred to what they refer to as undocumented aliens. Some hospitals get disproportionate share payments and may provide for emergency treatments defined as pulmonary edema, severe hyperkalemia, or overt uremia, but not routine dialysis. 40 of 50 states have programs that will help pay your hospital to do some. I happen to live in one of the 10 states that does not. So there are two positions on this problem. One is that regular dialysis is standard of care and is the just approach. The other says, do we have the right to spend other people's money? I don't have the answer to this question, but that is the challenge. So if you have a patient who does not have coverage, he will not get coverage from the feds just because he's got end-stage kidney disease, unlike a patient who's a full-fledged citizen. So this becomes a problem that influences what's available and whether or not you have a realistic alternative or not. And at least at a minimum, the patients need to know this. So when working up a patient with newly discovered elevated creatinine, try to remember to assess the proteinuria. Treat hypertension as close to 125 over 80 as you can get without side effects. Use an ACE or an ARB and probably a loop diuretic as part of your basic regimen. Remember, the eGFR is just an estimate. It should generate thought, but not necessarily action. And as the primary provider, you have a role to play in assessing your patient's suitability for dialysis. Have a real conversation with him or her and don't take the view that, of course, you'll do dialysis when the time comes. No dialysis is a viable option in the right circumstances. So I'm going to quit at this point and see what kind of questions I've managed to raise or issues I've provoked going through all this, and see if Dr. Feldstein wants to comment on the old folks category thing that I talked about.
The best folks, the best folks.
Well, of course,
Thank you.
we're all the ones who survived.
That's right. Thank you so much for your great talk, Dr. Wright. I'm not seeing any questions from our learners at this time. Hopefully, we'll be getting some questions, but since I am biased, I do want to just go back and comment. Dialysis is not the option for many people. I think talking about what dialysis can take of a, just take from a person, an individual who previously was living independently, to figure out how to suddenly have this huge lifestyle change in addition to physical, it's just so much of your life changes when you're on dialysis. And I think, at least in my patient population, I work really hard to describe to patients what dialysis can look like. And again, I'm biased, so I focus more on the limitations that it can give. I know one of the things that, and I don't know if many of our MAVEN members are experiencing this, but I remember when I was in training, how amazed I was that people could arrange for like vacation while you're on dialysis. That was the coolest thing, that that there is a network of clinics that will make sure your patient can go see the Grand Canyon.
Or the grandkids, as the case may be.
Exactly. Yeah.
Yeah, well, what I've told many people is I've counseled well over 3,000 people about chronic kidney disease and dialysis, and only two of them said, "Oh, yippee skippy, that sounds like fun." And I thought they could go to our local state mental hospital and get in. So nobody wants to do dialysis. That's just part of the given. But a
Yeah.
common scenario that you run into is you're having a conversation with an older couple, somebody my age, let's say, and you're talking about it, and they're not really eager, and they're thinking, "Gee, is this really worth it or not? Is this something I want to get involved with?" And the kid, who usually the one who lives furthest away, says, "Oh, daddy or mama, whoever it is the patient, you got to do this," because they don't want to be worried about, well, mama or daddy while they're living, miles and miles away. They're going to worry about them anyway, so it's a false hope. But it's the kind of thing where I've seen many a parent talked into it. And one of the problems is that, my wife and I got married in our 20s. We remember being in our 20s. We remember each of us being in our 20s, and we can look at each other. And while we've been together 55 years, we still know we're not in our 20s anymore. But we've always been old to our kids. So I mean, they all think of us as old. Now they're getting old too because they're all in their 40s. But I mean,
Yeah. Oh, we have a talk. So the SGL2 are not effective for less than 20 for your EGFR. What do you recommend when your patient is nearing the EGFR to start dialysis?
let,
And
let me
what?
re, let me, let me,
Oh,
let me
sure. I'll let you
re,
get to it.
Yeah, let me reframe the question. It's not that they're ineffective, they're just untested. All the people
Right.
in the original studies that got the approval from the FDA had eGFRs greater than 25. So the current recommendation is to discontinue the drug. That's the FDA, that's the approved official mantra. A lot of people take the same question you do. If it seems to be helping and it's keeping things slowing down, why risk upsetting the apple cart? I'll come to that one too.
Do
Uh,
you see any potential harm in continuing the SGL2 for
Well,
patients?
at some point, by the time you get to end-stage kidney disease, they're not going to be effective because you're not going to get the diuretic effect or any of the other potential benefits from it. You're going to have to use dialysis to do volume control and that kind of thing. So there is a point of diminishing returns. Exactly where that is yet to be defined. My bias is that the studies will be done and show that you get a little additional benefit continuing it into the 20s and the 15s. But at some point after you get to stage 5, it's probably not doing any good. And it does cost a couple $100 a month out of pocket area on top of what you're getting on your Part D coverage if you're on Medicare.
Yeah.
So the other question had to do with ACE inhibitors in patients with childbearing age. So the question, the problem is that ACE inhibitors are a pregnancy category. So I forgot what letter goes with it, but it's a bad one. You don't want to be on ACE inhibitors and pregnant at the same time. That part I remember. And the basic idea is if you had somebody who really wanted to get pregnant, first off, they need to know if their blood pressure is that much of a problem, they're going to be a high risk pregnancy. So they should get pregnant on purpose, not by accident. Secondly, you can see, I would stop the drug during the time they wanted to do it, but to take them off the drug just in the hopes that somehow or other they'll conceive sometime in the next 5 years is probably not a good risk calculation. So the way I would put it is, in informed consent terms, is if you stop the drug, you run some risk that you'll lose benefit from protecting your kidneys. The presence of kidney disease increases your risk of miscarriage, increases your risk of a malformed fetus. If you want to get pregnant, you should stop the drug and we'll switch you to whatever you're currently using, Aldomet or hydralazine or whatever is currently in, and try to manage it that way. But if you don't get pregnant in the next fill in the blank number of months, you probably should go back to this drug and go back to your contraception. That's, yeah, all those numbers are undefined. There's no evidence base that says 6 months, a year, or whatever, but the longer you go, the less benefits you're going to get from it. So, and we don't have a lot that protect people's kidneys. So
Unfortunately.
I hope that I answered the question that was being asked about the ACE inhibitors. The question is, why do we have a delay of 12 months to see preservation? The answer is no, I don't know the answer to that, nor did the people who did the study. They just thought it was sufficiently worthwhile to point out that it was different. So I'm calling it out to put it to everybody's attention as well.
I wonder if one of the, again, from my patient population, one of the things that I have been aware of clinically is, and then also I know that there's ever-growing data on this, but the fastest, or I guess the population that is initiating dialysis at the fastest rate is for individuals over the age of 80, I believe, and that's thought to be related to the Medicare Advantage population. Wonder if that's something that you've seen or you've heard about?
Well, demographically, the over 85s, the old, or the most rapidly increasing segment of the population. So my
Yeah.
interpretation of that is we're offering dialysis to everybody willy-nilly. And sometimes whether it's a good idea or not. So if it's growing in the population is growing, so is going to be the rate of end-stage kidney disease, because
Yep.
we're not being discretionary. One of the studies that doesn't get enough, if this doesn't get I'm sorry, I lost my train of thought trying to read the next comment. Let me back up. So the issue with the study that doesn't get remembered is back in 1970, the University of Missouri had a nephrologist who was trained in dialysis, but they didn't have a dialysis unit. So they had a lot of people they were accumulating with advanced chronic kidney disease, and they were getting their creatinines measured and all that with some regularity. And what they did was a study to see what happened in these patients where there was no dialysis available. So they were followed until death, basically. And once patients got to a creatinine clearance of less than 5, this is a measured creatinine clearance, not a calculated clearance. When the measured creatinine clearance got to less than 5 milliliters per minute, the survival rate was 50% at 90 days, but some people lasted 2 or 3 years. Now, if you look at the notion that 20% of your population that you start on dialysis is going to die in the first 90 days, that means a substantial fraction of your population didn't get any benefit from doing dialysis. They'd be just as well off to stay home and to avoid all the hassles. There are beginning to be more studies done in frail elderly patients that show that any gain in life is basically spent in the hospital or in the dialysis unit, not at home. And if you ask people what they really want, it's not the dying. They want to be home with their grandkids or with their spouse or whatever. They don't want to be in the hospital. They certainly don't want to be in your dialysis unit, which kind of leads me to the question of that we were asked about PD versus hemo. The difference, what I was explaining to patients is the difference between hemodialysis and peritoneal dialysis turns out to be lifestyle choice. With hemodialysis, you spend chunks of time 3 times a week doing dialysis, generally about 5 hours by the time you start getting there, getting on, doing it, getting off, and getting out, plus whatever transportation time you got going home. With peritoneal dialysis, you do a little bit here and a little bit there and tuck it in around the edges of the day. But by the time you get to the end of the week, it's about 6 of one, half dozen of the other. So it depends on whether it's easier to do it in chunks and get it over with, or do it in little pieces and tuck it in around the edges of the day. Now, I usually tell them that after I've given them my sermon, which basically says the reason to do dialysis is not to avoid dying, because they didn't have to come see me to figure out they're going to have to die of something. They already knew that anyway. Really, the question was what's it worth to them? If they have positive reasons for getting up in the morning, things they want to do, and people they want to be with, they'll generally do okay most of the time. And if they have a bad day or a treatment complication, they can say to themselves, well, today is a bad day, but yesterday was okay. I'm hoping tomorrow will be okay. And if I wasn't already doing this, I'd be dead from my kidney failure. Folks who decide to do this kind of stuff because they're just not sure they're ready to go, prepared but not homesick, as one fellow put it to me. Folks get over being afraid of dying real quick when they have to work this hard at staying alive. Said another way, if the glass is half full, this is a reasonable thing to do. If it's half empty, it's more trouble than it's worth. Got lab tests to measure kidney function, don't have any lab tests to measure what it's worth to you. We got to do that the old fashioned way, talk about it a little bit. And then I'd go into discussion about advanced directives and CPR and all that kind of stuff and put it into a context for them. So that's the real difference between PD and hemo. They both work, but it's a lifestyle choice.
Yeah.
My dialysis nurses would want me to do PD in the event I got kidney failure because they wouldn't want me in the clinic with them.
You'd be running that too. I think we've got one more question about SGL2.
Can't see it.
There's it says, do SGL2 inhibitors cause an initial drop in eGFR? Is it a bar to using in some instances or no?
So the thing to recognize is that these drugs are diuretic. And it also gives you glucosuria. I've seen consults from MAVEN people because they're reporting glucosuria. If you're on these drugs, you're going to have glucosuria. That's part of the deal. That's how they work. But the diuretic effect can be significant and can be in the 5, 6, 7 kilo range kind of thing, depending on how much edema and how out of control their glucose was to begin with. So when you're doing this, if the patient's already on diuretics because you're trying to control the edema to get their blood pressure down, it's fairly easy for the blood pressure to go down fairly precipitously and for an initial decline in eGFR to occur related to the interaction of the drug and the interaction of the ACE inhibitors and all that. And just to confuse the issue, some of the renal physiologists think there's some independent effects on eGFR or on glomerular filtration rate too. So the story may not just be all volume and ACE inhibitors, but the big part that concerns us is volume and ACE inhibitors. So if you're going to start these drugs in somebody who's already on a good dose of an ACE inhibitor and already on a good dose of, let's say, furosemide, you might want to think about cutting the furosemide dose down a little bit before you started the SGLT2, or maybe even consider cutting the dose of ACE inhibitors in half for a while, just to kind of ease them into it. It's not a contraindication. It's just it's a kind of an art finesse thing with instituting the drug.
Can you see this question?
Yeah, I can see that. So finerenone is basically a synthetic aldactone inhibitor, aldactone-like drug, but it's supposed to have less hyperkalemia and have less mineralocorticoid effect on the kidney tubule, would have the beneficial effect on the heart. It has not become widely popular yet. It's here again, the academicians decry the use of the drug. I have no personal experience with it with which to compare it, so I don't know whether the hyperkalemia issue is real or not. But that's the theoretical advantage of using it as opposed to spironolactone. It's expensive, but so is spironolactone. So I don't know what the retail differences would be in those two drugs. So a real issue there. All these new drugs are expensive. The GLP-1 inhibitors is all your patients trying to deal with their obesity know, which is why you got all these fly-by-night people who are compounding their own GLP-1 inhibitor and selling it to you for a small fortune.
With no regulation, minimal regulation.
Yeah. Okay, hyperkalemia is common. You worry about treating it if the patient's showing EKG changes, which generally is going to be over 6.5 or 7. A lot of patients with CKD run potassiums of 5.5, 5.8, something like that. I generally treat those with trying to get them to get off the big 5 for dietary potassium, which is tomatoes, potatoes, bananas, citrus fruits, and salt substitute. You get them off those 5 things, you generally do okay. If you need to treat them, there are 2 different drugs available. One of them is called sevelamer. The other one is zirconium something. I forgot the Lokelma is the trade name for it, and I can't remember the generic name. It's not a trade name; it's a scientific name of the chemical. Both of these drugs are expensive. They do work, but here again, you're layering yet another drug on top of another drug to deal with a side effect, which probably defeats the utility of all of this. So all the drugs we have seem to have impacts. The SGLT2 inhibitors caused it.
I was just going to say a management practice that I think is important about thinking about hyperkalemia is just making sure that patients are moving their bowels regularly, right? That's
Yes, absolutely.
That's another important.
Excretion in the bowel is the big alternate pathway.
Yep. So if patients are cutting out bananas, also making sure that they're still moving.
Yeah, we get another source of bran. So the diuretic effect you get from the SGLT2 inhibitors or from furosemide will promote urinary potassium excretion, which generally is a good thing as well. So it's a potential benefit.
I think in your answer about the hyperkalemia question, it's looking at EKG changes, which implies that you have a baseline EKG. So just making sure that you have that to look for what someone's baseline is, particularly for their T waves as their potassium trends up.
T waves I don't find to be all that useful as things like first and secondary heart block that you have to worry about because those can be subtle signs of hyperkalemia. The T wave thing, if you got it, you got it. It's pretty obvious.
Yeah, that's
If they're
usually that's usually
if they're sine waving, that's pretty obvious too, but you don't want to see that. So
yeah. But just making sure that you do have a baseline to compare for that inevitable 5 o'clock patient on a Friday.
yeah, absolutely.
These guys have great questions. Just looking to see if there's anything that I want to make sure we talk about. I put in the chat the little blurb, just a reminder about the CME survey for our learners. And we hope that you enjoyed today's session. And if you're interested in attending a future session or even anchoring an educational session, just let Kristen Talbot, K. Talbot at mavenproject.org know. All clinics can anchor an educational session, which means that you get to pick the topic, the date, and the time, and the session. The only requirement is that someone from your clinic attends the session. And for mentoring, just as a reminder that the MAVEN Project offers mentoring to all of our community providers at any point in your career. We help with individuals who are new to practicing as a provider for any challenging cases to prevent burnout or building teams or even executive coaching. We offer specialty specific mentoring like EKGs or CGM, the continuous glucose monitors, or also for monitoring and managing chronic kidney disease. So I think, and then we'll have a recording of today's session, and it will be in the library with all of our other recorded sessions. I wonder if we have any other notes from our learners. Just looking to see. Do you see anything, Dr. Wright? I think we might have gotten them all. I guess one thing that I think that's important just to emphasize, I thought you brought this up in a great way, but do a UA. It's a quick, easy test. And I know in speaking of how you had mentioned that for trying to capture active urine sediment, it's better to get that earlier in the day than later in the day. So how would you feel about like giving a urine sample cup to your patients and asking them to collect it in the morning and then turn it in if they can that day, if it's been in the fridge?
You're going to do that. You want to have them try to turn it in on their way to work or something, or to wherever they go.
Yep.
Because you don't want it sitting around. The cells will all break up if it sits in the urine too long.
Yep.
They don't have to see you, but they do need to see the lab tech or the lab receptionist anyway.
They need it dropped off. I think we may have gotten all of the questions. Oh, that's a nice one. There's it says when the nephrologist becomes a primary care and they help manage immunizations.
There we have a captive population in the dialysis unit. Shooting them for the flu is relatively easy.
That's right. It makes everybody healthier.
I don't know that it makes everybody healthier, but you worked all this effort to try to get them going and have them die of the flu or COVID is really annoying.
For many people. But I appreciate that so much. I think that really helps with the population. Um, it'll be exciting one day when we have a Hep C vaccine, and then we can make sure our patients on dialysis get it.
I
I
think
think
most of the patients are waiting for the Star Trek pill, the one where Doc comes by and gives the pill to the patient and they get cured of their kidney failure and get off dialysis. That's the one they're all looking for.
yeah, you and me both. It would be great if we had something like that, but I think for now we'll have good nephrologists who help manage us while we're waiting for that to be invented. I think I'll probably wrap up our recording and just again say thank you to everybody who attended today's talk, and it'll be the recording will be posted in a few weeks. Thank you for all of your questions, guys, and please keep them coming. Thank you. Thank you, Dr. Wright.